Okay, hello everyone. So today I'll be explaining about chronic bronchitis, bronchiectasis, and asthma. It's a pretty big question depending upon how much you're going to answer exactly, but I think you should know this pretty well because it's also important for your clinical years. I'm just going to run through it a bit fast, and if you want to learn anything more specific, then I'd suggest that you watch specific videos on it on YouTube, for example, or you could do your own search on Google. So essentially, when you look at, sorry, just a second. Yeah. So when you look at pulmonary diseases, uh, and especially if they're diffuse, that is, they're affecting many different parts of the lungs at once, they can be classified into either an obstructive or a restrictive disease. Now, in obstructive diseases, as the name suggests, there's some sort of an obstruction. And here we're talking about obstruction to the airways. And we know that airway includes not only the trachea and the primary bronchi, but also the bronchioles, right? And all the further divisions that we have. So, under obstructive, we have got four main diseases that we talk about, which is bronchitis, bronchiectasis, asthma, and emphysema. I think emphysema is a separate question, so we'll be covering only bronchitis, bronchiectasis, and asthma here. Now, um, like I said, there's some sort of an obstruction in the airway, and when there's an obstruction in the airway, there's going to be an increased resistance for the flow of air through the airways, right? And what's going to happen is um, the part of the lung that's beyond this obstruction does not get much air, okay, and therefore it will be devoid of oxygen, and therefore if it's diffuse enough, then it can actually cause hypoxemia and hypoxia. Now, in a patient with chronic obstructive pulmonary disease, which I'll again explain that in the coming sections, it mainly includes, bronchitis, emphysema. So over here, what's happening is you have these values called forced vital capacity and forced expiratory volume 1. Essentially, if you look at this, these are the lung volumes, right? Your vital capacity is the sum of your tidal volume, which is usually 500 ml, your inspiratory reserve volume, and your expiratory reserve volume. So, yeah, this is the value. Now, um, what's going to happen is because there's some sort of an obstruction, okay, the force with which you can expirate or you can expire the air or the air in the lungs within 1 second will obviously decrease because you're not able to like have sufficient flow, right? So that's the problem over here. And that's why your expiratory volume at 1 second, within 1 second, the volume of air that you're going to expire is going to significantly decrease. And the forced vital capacity, right, which is this vital capacity, but forced as in the maximum amount of vital capacity volume that you can forcefully expirate, will also slightly decrease, but not as much as your forced expiratory volume in 1 second. And that's because here you're mainly having an obstruction with the airway itself, and not a severe problem with the filling of air within the lungs. Although, because you have a blockage in the airway, what can happen is more air can begin to get filled within the lung and you can't really breathe out as much. So gradually your lungs start becoming filled with more and more air. And at the same time, like I mentioned earlier, there can also be the case of your like certain parts of your lungs not getting enough air because of this obstruction. So it goes both ways. Like you're not able to expire enough air, and therefore you have collection of air within the lungs. At the same time, there are many parts of the lungs which are not able to get air, and that can cause hypoxemia because lack of oxygen into those spaces. But if you look at the ratio, FEV1 versus FVC, the FEV1 decreases much more significantly, and that's why this entire ratio decreases. This is useful if you're looking at this chart. I really love this diagram because it really helps in clinical situations to assess whether a patient has got a restrictive lung disease or an obstructive. This is just for your clinical information. It's always good to know this, especially for pathophysiology. But I guess learning this for patho will help you understand the concepts as well. So FEV1 versus FVC, if it's low, then you assess FVC. And if it's like, let's say normal or high, you go for obstruction. Well, you can just follow the flowchart. It's pretty simple. I'm not going to go too much into it. Right. So that's basically the second point. Now, the expiratory obstruction may result from an anatomical airway narrowing, as in the case of asthma, or it could also be because maybe there is some sort of a damage, some trauma, or maybe there's a tumor, that can cause an anatomic airway narrowing, or there can be a loss of elastic recoil, in which case there will be emphysema. Um, so emphysema and chronic bronchitis, they are grouped together under COPDs, chronic obstructive pulmonary diseases. Okay, so the difference between the airflow obstruction in chronic bronchitis and emphysema versus, let's say, asthma is that in asthma, it's more of a reversible airflow obstruction, whereas in COPD, which includes chronic bronchitis and emphysema, there is irreversible airflow obstruction. Now, that is compared to restrictive diseases. Restrictive, as the name suggests, is that there is some restriction to the lungs expanding and getting filled with air. And that could be because, let's say, the chest wall isn't large enough, or maybe the muscles that help us with respiration, maybe with the diaphragm or with any of the accessory inspiratory and expiratory muscles, maybe they're not functioning well enough, and that's why there is a restriction that is created, and therefore the lungs are not able to like completely expand. Or maybe there is massive fibrosis, or there's diffuse fibrosis of the lungs, and you know that fibrosis basically prevents the flexibility of the lungs, right? Because it's like hardened. So that causes restriction against proper filling of air, filling of lungs with air, and that's why it can't really get like expand. Here you have a decreased total lung capacity, and as a result, your inspiratory reserve volume and expiratory reserve volume will naturally decrease. Whereas your FEV1 may be normal. And why is that? And that's because when there is restriction for the lungs, it's easier for the lungs to like just get back and sort of, how do I say it, constrict and become smaller rather than expanding, right? And therefore, if there's greater tendency for the lungs to like sort of just collapse or to like just become constricted, then the force with which the expiration occurs, or the force with which the air is expired from the lungs, is really like powerful, right? Because excuse me, because not only are you expiring with your own voluntary control, at the same time the lungs are restricted, and therefore they have a higher tendency of just squeezing the air out of the lungs. And that's why your forced expiratory volume in 1 second might be normal or just slightly reduced. So in this case, the ratio, that is FEV1 by FVC, what's going to happen is, uh, so I'll just put it over here actually, FEV1 divided by FVC. So if you look at this, FVC is significantly going to decrease, right? Um, and if the denominator decreases as compared to FEV1, or the numerator, then the ratio as a whole is either close to normal or it slightly increases. So that's the difference, and that's why you see over here they say normal or high, assess FVC, and if you follow the flow chart, you can go towards chest wall disorders, or neuromuscular disease, obesity. All of these are going to cause restriction. Uh, they're going to restrict the lungs from expanding completely. Okay, it could also be interstitial lung diseases, which is going to cause fibrosis eventually, which will then cause a restrictive disorder. So that's the case with restrictive diseases, just in brief. And you can remember stiff lungs in order to remember restrictive diseases. So the examples that could lead to that are pleural diseases, ARDS, pneumoconiosis, lung inflammation, or any sort of pneumonia that could cause fibrosis. Right, so let's just look at this picture. You have emphysema and you have bronchitis. So what's going to happen is, um, let's say in the case of bronchitis, bronch plus itis, itis means inflammation. So there's an inflammation of the bronchi, and as a result, there's narrowed airway. Okay. And as part of the inflammatory process, there will also be increased mucus and there will be tightening of the smooth muscles, which will all again lead towards the narrowing of the airways. And in emphysema, what can happen is that there will be a collapsed airway, all right? And because of the inflammatory process, the septa of the alveoli can also get damaged, and this will lead to decreased surface area within the alveoli because the septa contribute to the surface area. And if the septa are damaged, the amount of elastic tissue is like decreased, right? Because septa is like made up of elastic tissue, which means that there's no sufficient elastic expansion and let's say constriction, and as a result it's more or less collapsed, like there's not much of functioning. It's just like a bag of air, like a bigger bag of air with reduced capabilities of constricting and expanding. So in essence it's just collapsed, it's functionally it's collapsed. It's not really going to help much. So there's either just air that's going to continue to like get into these spaces and it's not going to get out because there's no elastic tissue to push it out, or it's just not going to get filled with air in the first place because it's collapsed. Like either of the two can happen. And again, if it's not going to get filled with air, then there can be hypoxemia. Okay. Um, and if it's going to get filled with air, it's just the lungs are going to become bigger and bigger, but not enough air is going to get out. So that's the case over here. Um, So, yeah. Now, the common manifestations literally for any of the lung diseases always just say dyspnea. If you can sort of trace the pathogenesis and the pathophysiology of the disease towards cyanosis, because let's say that there's probably hypoxemia, right? When there's hypoxemia, there'll be cyanosis and there'll be bluish discoloration of the skin. Then chest pain, definitely. Cough because of accumulated secretions. Always remember that whenever there's inflammation of the airways, know that the airways contain mucus secreting glands. And when there's inflammation, there's a very high tendency for these glands to increase in their number and to also increase in their activity. When that happens, there's going to be increased mucus production. However, that is in the initial stages of the inflammation. As the disease progresses, or if the etiology or the stimulus of this inflammation is not removed, the inflammatory process will eventually lead to chronic inflammation, right? And in chronic inflammation, you know that there's going to be fibrosis towards the end. And if there's fibrosis, these glands are ultimately going to get destroyed. Okay? So in initial stages, for a large period of time, there's going to be increased mucus production, and even there'll be increased like number of glands, and there'll be hypertrophy of these glands. So there's going to be cough as a result of accumulated secretions. Um, Also, another important point is that if there's inflammation of the airways, the mucus layer or the superficial layer, okay, in the lumen is going to obviously be inflamed. It's going to get damaged, right? And you know that in the airways, like in the bronchioles and in the bronchi, they contain a lot of cilia, right? The cilia helps in pushing the mucus towards the pharynx, like through the larynx into the pharynx. And that's why we cough the sputum out. So eventually, because of inflammation, the cilia will get damaged and the mucus will reside within the lungs, which will further contribute towards the progression of the diseases towards a more severe situation. Okay, that's just another logical point that you have to remember. And of course, if the septa are going to get damaged, as I've shown over here, well, typically the capillaries are present around the alveoli over here, and more towards, the bronchioles. Like this is where you'll find all these capillaries. So when the bronchioles are going to get damaged, the vessels can get damaged as well, and that can lead to the leakage of blood into the alveolar spaces. And if it's diffuse enough, it can cause hemoptysis as well. Okay. Other than this, there can also be lung cancers that can develop, lung infarctions, etc. Now, under chronic obstructive airflow diseases, you have COPD as well, just so you remember. So there's diminished ability to expire the air out, and again, it's mainly because of obstructive situation. With restrictive, it's usually possible, like the lungs will like sort of constrict very quickly. They won't really expand as much, so you can just breathe out the air really quick. Although the volume that you're breathing out, or the volume that you're forcefully expiring, will be reduced naturally because the lungs are not expanding enough to be filled with sufficient air in the first place. So naturally, the amount of air that you would expire would be reduced. Although the force with which you expire will be pretty good. Okay. So now changes in spirometry. The reserve volume will, the residual volume will naturally increase because, again, like I mentioned, these spaces will begin to get filled with more and more air, but they're not able to get out of the lungs. Um, then reduced forced vital capacity in because the inspiratory volume and the expiratory volume will be decreased, right? But there'll be severe reduction of FEV1 compared to FVC, and therefore the ratio will be reduced. The total lung capacity, however, will increase because of the air trapping. And this total lung capacity increase is mainly contributed by the increased residual volume. And of course, ventricular perfusion mismatch, right? The areas that are going to be blocked, right, because of the narrowed airways are going to get supplied with less oxygenation. And we know that the lung has this unique ability to have this reflex vasoconstriction in areas which are poorly supplied with oxygen, and therefore there is a mismatch between ventilation and perfusion. Now, again, um, the obstructive airflow diseases will include asthma, chronic bronchitis, emphysema, bronchiectasis, cystic fibrosis. So, again, coming back to COPD, it's the same thing that I mentioned earlier. Um, and most patients, it's important to note that most patients show both signs of chronic bronchitis and emphysema. Usually, when there's chronic bronchitis, eventually it will lead to emphysema. Again, why? Because chronic bronchitis will be a breeding ground for further destruction and further inflammation, and that inflammation will destroy the alveolar septa, which will then basically cause increase in the what do you say, the bags of alveoli over here will become larger and larger, and that's basically emphysema, right? So that's why it's like grouped together and referred to as COPD, and most patients show features of both. And the major trigger for this is cigarette smoking, smoking cigarettes. Right, so in chronic bronchitis, first, what happens? Well, if you look at these two pictures, the overall size of the entire airway itself over here, right? If you look at the outermost diameters, it's going to be more or less the same. However, the diameter of the lumen is significantly decreased. The most important thing that you need to know when you're dealing with these obstructive diseases or any sort of diseases in the lungs is you need to know how exactly the airways are changing with their diameters. Okay, both the outermost diameter and the innermost diameter. It's very important because these vary like between different diseases. Okay, one second. Um, Okay, so it is recording, right? Yeah, it is recording. All right, my bad. Sorry, I had to break in between because I had to see if I was actually recording it. Uh, Let me share again. Yeah, sorry for the interruption. Yeah, so like I was saying, uh, so you have to look at the diameter. So in this chronic bronchitis, you can see that the diameters are more or less the same. Maybe there can be subtle variations. Um, but what's going to happen is in the diameter of the inner lumen, you can see that there'll be inflammation, right? Chronic bronchitis, inflammation of the bronchi, there'll be inflammation of the mucosa. So there'll be inflammation of the mucosa, okay, and increased number of mucus glands, which means there'll be more mucus, okay. All of this will contribute to narrowing of the lumen. On top of that, there's going to be hypertrophy of the smooth muscle. It's so very important that you know when there's inflammation, there's going to be hypertrophy of smooth muscle as well. So, all in all, it's going to lead to decreased lumen size and increased mucus production. What's going to happen is, as a result, you're going to have the lumen narrowed and filled with mucus. And that's why, usually on clinical examination, you can hear wheezing, you can hear, I think it's called ronchi or rails. You can hear the flow of air having this whistling sound because the lumen is narrowed and the air is turbulent as it hits the mucus within the lumen. Okay. And when you look at the definition of the clinical diagnosis of chronic bronchitis is basically a chronic productive cough lasting at least 3 months over a period of at least 2 consecutive years, okay, with no other identifiable cause. Now, 90% of the cases it's caused due to smoking and this highly productive cough. At this stage, the cilia are still working pretty well, I would say, and they're able to push the mucus into the pharynx and they're able to like spit it out. The causes of this inflammation could be is mostly related to cigarette smoking, or rather, I would say the cause of this chronic bronchitis to occur is because of cigarette smoking. It's a stimulant that will cause the inflammation. Because look, inflammation need not necessarily be infectious cause. The etiology could be infectious and non-infectious. In the case of infectious, it could be RS3. It could, I think, probably be some other bacterial infections as well. But non-infectious etiology could be cigarette smoking and atmospheric pollution. So all of this will irritate the mucosa, and as a result, there'll be inflammatory process which will cause mucus hypersecretion and chronic inflammation. And like I mentioned, there'll be hypertrophy of mucus glands, there'll be increase in goblet cells, and all of this will lead to smaller internal diameter. Now, in the mucosa, you can see that there'll be increased WBC infiltration, okay, but without eosinophils necessarily, because uh, in asthma, you can see it's a hypersensitivity reaction, and that's why eosinophils are involved. Whereas this is not exactly a hypersensitivity, it's just irritation, okay? And that too, it's a chronic irritation. It's not like if a person starts smoking like or smokes like once or twice, they're going to develop a chronic bronchitis. It's chronic. It has to be for a long time. Now, so yeah, that's pretty much it. And also, it's important that if you look at the order of the division of the airways or the passage, you have the primary bronchi, and then you have like multiple divisions. You go for terminal bronchioles, respiratory bronchioles, alveoli, etc. So the chronic bronchitis and what's going to happen is there'll be bronchiolitis as well. So even the bronchioles will get damaged. And if the bronchioles are going to get damaged, there'll also be a small airway disease. Okay. And yeah, that's eventually going to also lead to emphysema. Right. Now the pathology. So macroscopically, you're going to see that the mucosal lining will be uh, the lumen will be small, okay? There'll be edema, they'll be covered with mucinous secretions. You can also note that because of this edema, there can be an increase in the outer diameter size as well, but that's mainly because there's edema, okay? But I would say focus more on the internal diameter. Now, also, there is a difference between the thickness of the submucosal gland layer to that of the entire bronchial wall. It's called the Reed index. So you just like compare the size. And normally it's zero point 0.4, but obviously because there is hypertrophy and increase in the mucous glands, there can be an increase in the thickness of the submucosal gland layer, and that will lead to an increase in this magnitude. So it's basically the numerator is the thickness of the submucosal gland layer, the denominator is the bronchial wall. Together, the ratio is called Reed index. Now, in severe cases, okay, there's fibrosis, okay, and what can happen is there can be obliteration of the lumen and can be called as bronchiolitis obliterans. Again, there'll be hyperplasia of the mucous glands. There'll be bronchial squamous cells metaplasia. This is basically, obviously, metaplasia, right? It's a conversion from one cell type to another cell type as a way of sort of adapting to the harmful stimuli. In which case over here it could be, for example, cigarette smoking, or it could be infections, etc. So the complication could be infections. It's a breeding ground, and corpulmonale because hypoxic vasoconstriction in those areas where they're not being supplied with enough oxygen can cause increased pulmonary vascular resistance, which can increase the hydrostatic pressure within the pulmonary artery, and that can cause increased pressure within the right side of the heart, can lead to increased oxygen demand by the right ventricles, and also there'll be right ventricular hypertrophy. And there can be a difference between the amount of oxygen that can be supplied at that point at an acute situation versus how much oxygen is actually being demanded by the muscles, by the musculature of the heart. And that can lead to a ischemia and consequently right side heart failure that will cause corpulmonale, in case you didn't know how it would progress. And because of metaplasia, there's also lung cancer. Do not forget this point. Now, clinical symptoms, bloaters, because lungs in COPD usually expand because air is coming in, but it's not going to get out, and therefore emphysema can occur as well. And it's called blue because of cyanosis. Okay. Um, there'll be hypercapnia because again, there has to be a exchange of oxygen and carbon dioxide. If there's no air entering many parts of the lungs, carbon dioxide cannot really leave, right? And also, if there's narrowing of the airways, how can you exhale the carbon dioxide which is built up within the alveolar sac? You can't. It's going to be very difficult. Therefore, hypercapnia. So hypoxemia and hypercapnia, and there'll be cyanosis as well. Okay, so I already mentioned most of these things, I guess. Then there's increased risk of infection. Um, yeah, I think I've covered all those parts. Then we go for bronchiectasis. Okay, so what is bronchiectasis? Why are we talking about bronchiectasis? How is it different from bronchitis, chronic bronchitis, and asthma? Let's have a look. So again, like I mentioned, look at two important points when you're comparing them. Look at the inner lumen diameter and external diameter, or the diameter of the entire airway itself. Over here, what you're going to see is you're going to see that the external diameter is significantly increased, okay? And the internal lumen diameter is decreased in both, sorry, not in these two. My bad. In bronchiectasis, you're going to see a significant increase in the external diameter of the airway, whereas in chronic bronchitis, you're going to find it to be more or less similar to the normal bronchus, or probably slightly there'll be some variation, but not as much as bronchiectasis. So here you have an enlargement of the airways. So you would think that, okay, if there's enlargement or if there's increase in the external diameter of the airway, then shouldn't there be an increased diameter of the internal lumen as well? And shouldn't that actually allow for better airflow? The problem is, again, bronchiectasis has to do something with inflammation of the airways, which means there's going to be mucus production increase, there's going to be hypertrophy, hyperplasia of the mucosa, and there'll be damage of the cilia. All of this will lead to narrowing of the internal lumen. So there's increase in the external diameter, but still there'll be a narrowing of the internal lumen, mainly because of excess mucus. So how is this different from chronic bronchitis with relation to the like the hypertrophy of glands, with relation to how much mucus is being produced? Let's have a look. So in bronchiectasis, again, this is a permanent dilatation of the bronchi, okay? And this dilatation is occurring because of the destruction of smooth muscle cells as opposed to the increased constriction of the smooth or increased activation of the smooth muscle cells in chronic bronchitis. Okay. There's also destruction of the supporting elastic tissue of the bronchi, and this is usually due to an infection which becomes necrotizing. Necrotizing infections could be some bacterial infection or any other sort of infection, which is severe enough to cause necrosis to a massive extent. Now, bronchiectasis is not a primary disorder. It's usually secondary to a persistent infection or obstruction caused due to a variety of conditions. So technically, you could say that the obstruction caused due to chronic bronchitis could lead to bronchiectasis, but I would suggest that you verify that using various other resources. Um, Epidemiology is uncommon today. Why? Because you have to go, it has to, it like the disease has to progress quite a lot to come to this stage, okay? Um, and over here again, like I'd mentioned earlier, in those who are having chronic bronchitis, okay, they can develop infections and that can lead to, technically it can lead to bronchiectasis as well. But because it's so uncommon today, like I would say it's something that you just remember, you know. And if they do ask, then you can make this connection and you can say that, okay, chronic bronchitis can eventually lead to emphysema and then bronchiectasis as well. So you see how it's connected, okay? Right. I just found that interesting, so maybe you might find it interesting as well. So the conditions that predispose is again bronchial obstruction due to tumors, due to foreign bodies, mucus impaction. It could be due to cystic fibrosis. Again, you know, cystic fibrosis, I think it's the CFTR gene, right? There's some problem that I think with the chloride channels, if I'm not mistaken, and that leads to increased thickness of the mucus, and mucus is not going to get cleared properly, and this can lead to secondary infections. Okay, and again, that infection can damage the smooth muscle cells, and that can lead to bronchiectasis. So, in a sense, a infectious etiology can cause chronic bronchitis and bronchiectasis. It just depends on whether the smooth muscle cells are going to get damaged or not. Typically, there's chronic bronchitis that can develop, okay, uh, and then that can lead to bronchiectasis. However, if the infection is mainly dealing with, uh, let's say, if it's not going to really cause a hypertrophy of the mucosal glands, and if it's not going to cause damage to the smooth muscle cells, it's just going to become chronic bronchitis. Otherwise, if it causes damage to the smooth muscle cells, it causes bronchiectasis. So that's that. You can also have other situations such as primary ciliary dyskinesia, where the cilia, like there's some sort of a, you know, autosomal recessive inherited abnormalities of cilia that will impair the clearance of the mucus, and this can lead to a breeding ground for infection, certain infectious microbes. And of course, Klebsiella and Staphylococcus aureus, or I think even with Pseudomonas, another hospital or nosocomial pneumonia, which is very severe, it can lead to a bronchiectasis. Now, pathogenesis. Okay, so you have opposing forces on the bronchial wall. Opposing forces, I mean smooth muscle cells trying to contract and the airways trying to expand in order to like allow for better airflow. Um, and yeah, that's one of the pathogenesis. Like basically just mention whatever I mentioned until now with regards to how the infection can cause damage to smooth muscle cells, and that will cause widening of the airways. But because of inflammation of the mucosa, that's going to cause mucus production, that's going to cause the narrowing of the lumen. You have bronchiectasis. Okay, so also the opposing forces can be the smooth muscle cells trying to contract versus the exudate or the mucus trying to get built up within the lumen and trying to like push the lumen outward. Okay, and eventually it's going to lead to an irreversible dilation because it's irreversible because the mucus is continuously going to get produced and it's going to stay there because even the cilia are damaged. But at the same time, the smooth muscle cells are also going to get damaged, and overall, it's going to lead to increased diameter, like increased diameter of the entire airway. But you basically have it irreversible. You can't really reverse it. So macroscopically, you have dilated airways. Okay, sometimes up to 4 times the normal, filled with mucopurulent secretions. Um, Gross examination, they can even like be imprinted onto the pleural surface. Microscopy, dilatation, inflammation, fibrosis, complication, hypoxemia, cor pulmonale, secondary amyloidosis, because if there's amyloid, basically because of inflammation, you'll have amyloid proteins going to get uh, improperly produced or they're not going to be degraded appropriately, and this can lead to deposition of amyloid proteins and result in amyloidosis. Um, Clinical manifestation, the most basic. Bronchostenosis is basically where you have narrowing of the bronchi due to compression by a tumor or due to a like fibrosis or calcification caused by an infection such as tuberculosis. Um, I think it can also be caused by aspergillosis infections, chronic aspergillosis or invasive aspergillosis. It can also be caused due to Wegener's granulomatosis. That is, I think, it's a necrotizing vasculitis infection or necrotizing vasculitis situation. Um, yeah, so that's that. Then we come to bronchial asthma. Now, this is interesting. Bronchial asthma is different from chronic bronchitis because it is it's not irreversible, it is reversible. So, what's happening over here is sure, you're going to have increased production of mucus, but the trigger for this asthma is not always present. It's just that um, the airways, okay, are more susceptible or they're very sensitive to certain stimuli, and therefore, even if those stimuli need not necessarily be a dangerous stimuli to like in general, because of this hypersensitivity or this like hypersensitivity of the airways, there can be a hypersensitive reaction which will result in the inflammation of the airways, okay, and it's going to cause narrowing of the airways, okay. So over here, you can have cold, there can be again smoking, there can be, for example, let's say perfumes, many people are allergic to perfumes. It could be because of some incense sticks, the ones like which you sort of light up and then it gives you aroma, if you don't know about it. It can be dust, it can be exacerbation, that is when someone has asthma, when they're hypersensitive, and if they perform sudden physical work, like excessive work, and if they get um, exhausted, it can suddenly result in a hypersensitive situation. Um, so yeah, all of this can cause inflammation of the inner layers of the airways, and this can result in narrowing of the lumen. Now, how, what exactly happens over here? Well, not only do you have inflammation of the lumen, okay, but you also have tightening of the smooth muscles as a response to the hypersensitive reaction. So both of them are contributing to the narrowing of the lumen. Also, those who are asthmatic, okay, they can, or those who are like, yeah, those who are like asthmatic, they have this chronic inflammation of the airways of the inner lumen, but it's just not as severe, and they don't have a severe production of mucus as opposed to chronic bronchitis or bronchiectasis. So that's the main difference over here. Um, so, and also the episodes are recurrent. So what's going to happen is narrowed lumen, right? It's a sudden aggressive episode. So suddenly they're at loss for breath. They're not really used to that sudden decrease in the airway, in the reduced airflow. So they're going to be gasping for air. They're not used to it. And there can be chest tightness. There can be dry cough because again, mucus is not being produced in a purulent situation, like in a purulent method. And it's particularly seen in the night and early in the morning because of the change in temperature. The hallmark is intermittent reversible airway obstruction. And here you're going to have a lot of eosinophils as opposed to chronic bronchitis and bronchiectasis, where you can have more of neutrophils and other WBCs. Now, eosinophils also produce major basic protein, okay? And they are responsible for the airway damage, which will eventually cause inflammation. There's also mucosal glands hypertrophy naturally because there's increased production of mucus. But of course, it's not to such a huge extent as it is seen in the chronic bronchitis and bronchiectasis situation. Now, again, like I mentioned, to trivial stimuli, this to stimuli that is normally not a stimuli to the general population, asthmatic patients are more susceptible, they're more sensitive to these. And status asthmaticus is basically a situation where there's a prolonged episode of this asthmatic attack. And if this is prolonged and if the patient is not used to that sudden reduction and severe reduction of airflow and oxygen deprivation, it can potentially be fatal. Now, it can also lead to a anaphylactic reaction where now not only are the lungs hypersensitive, but the hypersensitive reaction that is affecting the lungs can become systemic, and it can lead to a anaphylactic situation or anaphylactoid situation. Um, now, yeah, that's pretty much it. And usually, the lack of exposure to infectious organisms in early childhood will lead to the patient being very sensitive. They're not really used to infectious agents, and this can induce hypersensitive reactivity to immune stimuli. Sorry, it can result in hyperreactivity to normally immune stimuli. Now, what's going to happen is there could either be a genetic predisposition to type 1 hypersensitivity, okay? It's part of this triad of atopic asthma, atopic dermatitis, and conjunctivitis. Um, I think I mentioned dermatitis as well. Um, yeah, and asthma can be subclassified as atopic, that is allergic sensitization, or non-atopic. In the case of both types, the episodes of the bronchospasm is triggered by something that is trivial stimuli, which is maybe cold air, right? Maybe stress, maybe exercise, or it could be respiratory infections, which for the most part won't cause such a situation in even those who are having lung problems. Now, so what's going to happen is even in the serum, IgE can be increased. And because eosinophilic reaction can induce inflammation of the airways, gradually there can also be increased neutrophilia. okay? Or there could be an increased number of neutrophils, and then that can result into a mixed situation where you have WBCs of all types being present in the mucosa. Now, did I repeat this twice? Oh yeah, I think I repeated this twice. My bad. Yep, and then you can also go into pathogenesis. You can learn about which interleukins are acting over here. It's not very, very important, but you still have to know this for your general inflammation question in the general part of patho anyway, so might as well just learn it. Okay, so just so you know, there'll be vasodilatation of arterioles, increased vascular permeability, all part of inflammatory process. Now, in non-atopic asthma, you don't really have allergen sensitization, okay? But when there are nasal polyps or when there's bronchitis, chronic bronchitis, there can be an abnormal beta-adrenergic response leading to bronchoconstriction, okay? So I think this mainly activates beta 2 receptors, if I'm not mistaken. And this could again be as a result of stress, exercise, other trivial stimuli. There can also be drug-induced asthma, okay? There can be occupational asthma where certain occupational toxins or toxins found in certain occupational environment can trigger this. Um, but yeah, macroscopically you can have occlusion of bronchi and bronchioles by mucus plugs, and they can become quite thick, but not as acute or not as thick as, let's say, chronic bronchitis, for example. There can also be bronchial spasm. Um, and microscopically, you can see I don't know how to pronounce this, but I guess it's Kirschmann spirals. There will be Charcot-Leyden crystals. Um, you should know these two, by the way. And how do you get these? Well, you do a sputum or a bronchial. You can either do a bronchoalveolar lavage, or you can take the sputum and you can do some culturing, and you can check it under microscopy as well. You can do some staining. Um, Yeah, and this edema, this increased vascularity, basically just mention all inflammatory signs. Okay, at one point you should be able to logically just derive these points like increased vascularity, edema, etc. Because many parts of the body are having this similar pathogenesis or pathophysiology. And diagnosis can be made during spirometry and methacholine test. Um, And this again, if you go to this picture, you can see that you can assess asthma through this process. So yeah, that's pretty much it for this question. It's a pretty big one, but I hope, like, I would say genuinely invest time into this question because it's actually very interesting. I can't cover every single top point because I don't think you'll even have time to cover all of these things in the exam. Like, the professor will definitely interrupt you and ask you questions. Because it's a pretty big one. So I think I mentioned the most important points to mention. And definitely please read extra on Amboss, on YouTube, on other notes. And I mean, I already take, like, most of these notes are from what we have referred to in the past for our own exams. So it's just copy pasted for the most part. So yeah, I think it should become easier for you guys to refer to the notes that we collectively have. So yeah, take care. Have a wonderful rest of the day and all the best for your exams. Okay, so stop recording.